Hi everyone. Unfortunately, the last video closed out before we were done, so we only, I believe, had like about 6 minutes on it. So let's get back to peptic ulcer disease and its management. The goals of peptic ulcer disease management include pain relief, allowing the ulcer to heal, doing patient education on preventing any complications, and preventing reoccurrences. In the treatment of peptic ulcer disease, proton pump inhibitors are the drug of choice. They're very effective. They have a duration of greater than 24 hours. They're very easy for the patient as they are once a day dosing, and PPIs help approximately 90% of gastric ulcers heal in about 8 weeks, and duodenal ulcers heal in about 4 weeks. If you have mild symptoms with no complications, you can use H2 receptors that we talked about previously, such as your Zantacs. We know that H2 blockers inhibit the hepatic cytochrome P450 system and can increase levels of some medications metabolized by this system, but these medicines are favorable for some individuals as they're less expensive than PPIs. Also, for treatment, other pharmacological agents include antacids, as they neutralize the acid. They're inexpensive, but they may require frequent dosing. Sucralfate enhances the mucosal defense and helps heal ulcers. Bismuth preparations stimulate mucosal bicarbonate, and they have antimicrobial actions against H. pylori. And then if you do have the diagnosis of H. pylori, then there are combination medications that will help in the treatment of that infection. Follow-up is important, and referral if necessary. So it's important to educate your patients if they see no improvement in 2 weeks to get back in touch with you so you can make a referral to a GI. If you're concerned that if it's a gastric ulcer rather than a duodenal ulcer, then it's important to go on and refer, because there is an increased incidence of these ulcers with gastric cancers, and then follow-up is necessary for anyone not responding to treatment. Let's talk about cholecystitis next. And we know that this is an acute inflammation of the gallbladder wall, which usually is the result of an impacted stone within the cystic duct that causes inflammation of the proximal end and causes obstruction. And it can cholelithiasis is found in 90 to 95% of patients that present with cholecystitis. We know that it's more prevalent in the Western societies based on our diet, and can affect 20 million Americans. And another interesting note, 75% of Native Americans over 25 are noted to have gallstones. On this slide, these are the risk factors for cholecystitis. Please review these. Let's talk a little bit about patho. As we mentioned, most cholelithiasis is a result of a cholesterol stone, and bile contains cholesterol in solution that can contribute to these stones. And so when there's more bile with cholesterol in it, it crystallizes and leads to stone formation. And due to the nature of the gallbladder, it's an environment for bile to have stasis, and therefore then these stones can form. We also know that females that have an increased intake of estrogen and are on oral contraceptives have increased biliary cholesterol. So damage to the gallbladder correlates to the amount of time the duct has been obstructed and the degree of inflammation. And based on the level of the inflammation, edema can occur and result in ulceration, gangrene, an abscess, or even a perforation. Clinical presentation, your patient may complain of a colicky pain, and 80% of the patients say they've had this type of pain before, and that it can be referred to the middle of the back up into the scapular area. They may complain of indigestion, nausea and vomiting. They may have a positive Murphy sign. And this is when you place a hand below the costal margin in the right upper abdomen, and you ask the patient to breathe deeply, and if the gallbladder is inflamed, they will experience pain and catch their breath as the gallbladder descends down on the hand. These patients may also have fever, which is usually low grade, and mild jaundice. Diagnostic tests may include CBCs to look for an elevated WBC, assessment of liver function test, ultrasound, which is the gold standard, and a radionucleotide test. So some differential diagnoses that may be associated with cholecystitis include pancreatitis. We always have to include the cardiac component, so an MI, peptic ulcer, appendicitis, pneumonia, and hepatitis. Management of cholecystitis includes a low-fat diet. Non-surgical would include stone dissolution, shockwave lithotripsy, and then there's always the option of surgery. Patient education includes weight loss, and as we talked about, low-fat diet, an alternative form of birth control, and menopausal women should be counseled for alternate methods to decrease menopausal symptoms than estrogen supplements if they are known to be developing gallstones. Let's talk next about acute pancreatitis. This is the inflammation of the pancreas and surrounding tissues, and it results from enzymes in the tissue causing more of a chemical burn, which leads to a systemic toxicity. Although there are many causes of acute pancreatitis, approximately 80% of all hospital admissions for this is a result of biliary tract disease, such as passing of a gallstone and alcoholism. The others are caused by infection, which could be mumps, hyperlipidemia, metabolic disorders, drugs, structural abnormalities of the pancreatic duct, issues with the common bile duct, results of surgery, and vascular disease or trauma. Although the exact pathogenesis is not known, it is thought that there is an impaction in the sphincter of Oddi by the gallstone causing swelling or obstruction of the ampule levator, and then you have the reflux of bile into the pancreatic ducts, injuring the acinar cells. This process of events causes an autodigestive process within the pancreas that can lead to shock and death without appropriate interventions. If the inflammation is limited to the pancreas, mortality rate is less than 5%, but if it extends beyond the pancreas, mortality rate is anywhere from 10 to 50%. Pancreatitis can be divided into mild or severe. Mild usually improves in anywhere from 48 to 72 hours and doesn't involve other organs. Severe is often associated with a multi-system organ failure, and you can have hemodynamic instability, renal failure, respiratory compromise. It can be life-threatening, and pancreatic necrosis with a gram-negative sepsis is 100% mortality rate unless there's been surgical debridement. So what might you see of your patient that might present to you clinically with pancreatitis? They may complain of a deep epigastric pain that's been persisting for hours or days. The intense pain, it may be refractory to large doses of narcotics. It's aggravated by activity. It improves when the patient is sedated or leaning forward. The patient may look acutely ill and have nausea and vomiting and abdominal tenderness with guarding. When working this patient up, it's important to have a good history and physical. You want a serum amylase, and you may note that may be elevated up to 3 times normal. You may have concurrent elevation in the serum lipase. The WBC may be elevated. The CRP may be elevated, which would indicate pancreatic necrosis. You're going to want to do a CT scan and an ultrasound if gallstone pancreatitis is suspected. On this slide, we see an assessment tool called the Ranson's criteria for admission based on certain factors for pancreatitis. Review this. Also, other differential diagnoses that you need to consider with pancreatitis include an acute abdomen, a pancreatic pseudocyst, a perforated duodenal ulcer, small bowel perforation, a mesenteric thrombus, a ruptured ectopic pregnancy, and an aortic aneurysm. Management includes IV fluids, being NPO, pain control, and Demerol is found to be very effective with these patients. Introduction of clear liquids when pain-free, and the amylase and the lipase have returned to normal, and then advanced diet is tolerated. For severe pancreatitis, it would require referral to a GI or a surgeon. There would be aggressive volume replacement, hemodynamic monitoring, and then monitoring of your CBC, your magnesium, blood sugar, lights, protein, amylase, lipase, and a CBC and calcium. You would need ABGs to manage and to assess respiratory status, and then TPN for nutritional supplements. What we previously talked about was an acute pancreatitis. This is a chronic pancreatitis that we'll go to next, which is a progressive inflammatory process, and it shows irreversible fibrosis of the pancreas, and you will see destruction and atrophy of the exocrine and endocrine glandular tissues of the pancreas. Alcoholism may be one of the main causes of chronic pancreatitis and is usually seen in 70 to 80% of cases in the industrialized countries. There could be hereditary pancreatitis, elevated triglycerides. You can see this with severe malnutrition, a tropical pancreatitis, or if there's been obstruction of the pancreatic duct. There are two characteristic findings in chronic pancreatitis, and one is the hypersecretion of protein without an increase in the ductal bicarb, and then inflammation. And then there's irreversible structural damage with permanent functional impairment. These patients may present with intractable abdominal pain with tenderness. You'll notice epigastric or left upper quadrant pain. It may be dull and constant, and it's often aggravated by food and alcohol intake. You will see weight loss as caused from the anorexia due to pain and nausea. There'll be malabsorption from the pancreatic exocrine system, and then there's going to be poorly controlled diabetes. And then diarrhea will be noted as well. Diagnostic tests associated with chronic pancreatitis include evaluation of how well the pancreas is functioning and x-ray visualization of it. So you may do some blood sugar testing. You may see that the serum amylase may be normal. There may be malabsorption noted by the fecal fat. There may be, you may need to have ordered an ERCP, a CT scan, abdominal x-rays. Other differential diagnoses are going to include peptic ulcer disease, mesenteric ischemia, pancreatic cancer, abdominal malignancies, or celiac sprue. Management goals include preventing further pancreatic damage, to manage the pain, and offer supplementation to exocrine and endocrine function. It's important to educate your patient on abstinence from alcohol, and they're going to be needing pancreatic enzymatic supplements to help relieve pain. They'll also need narcotic analgesias. They'll need to be on a low-fat diet because they're not able to process the fat. They'll need insulin and the potentials of surgery. Okay, let's talk now on hepatitis. And so we know that there's many causes of acute hepatitis. And these include viral, non-viral, metabolic, vascular, related to drugs and other toxins. Let's first talk about hepatitis A, which is a single-strand RNA virus. It's declining in its prevalence. Per these slides, it was one case in 100,000 in population. But we know that there's been a recent Hep A outbreak in Kentucky, so you have to be more aware of that if your patient comes in with symptoms that may be suggestive of a hepatitis. It's caused by contaminated food or water. Risk factors include crowded conditions. It's transmitted by the fecal-oral route and has been detected in blood. It has an incubation of about 30 days but can last up to 2 weeks. And it's excreted in the feces 2 weeks before the symptoms and rarely after the first week of illness. It doesn't have a chronic state, but full recovery may take approximately 1 year. Hepatitis B has a DNA hepatovirus with 8 different genotypes, and it reproduces in the liver. Its incidence has decreased significantly since the 1990s, and now there's 1.5 cases per 100,000 in population. But we know that more than 1 million people have chronic hepatitis in the U.S. We also know the high-risk groups include male homosexuals, IV drug use, first-generation immigrants from an endemic region, people with multiple sex partners, nurses, physicians, dentists, and clinical and pathology lab workers, and hemodialysis staff and patients. Transmission is by direct contact with infected blood or blood products and sexual contact. Hep B is found in the blood, semen, cervical secretions, saliva, and in exudate from wounds. It has an incubation of 12 to 14 weeks, but can be anywhere from 6 weeks to 6 months. Hep C is a single-stranded RNA virus with 6 genotypes and 50 subtypes. Genotype 1 is the most common in the U.S. Incubation is anywhere from 6 to 7 weeks. Transmission is similar to Hep B. Risk factors include IV drug use, sex with an IV drug user, possible transmission through tattooing, and body piercings. Less than 25% of these patients that are Hep C positive are symptomatic, and most acute cases go undetected. We also know that alcohol consumption increases the chance of having Hep C. So for Hep D, we know that that's a defective RNA virus, but you have to have the Hep B antigen for replication. So you can't have Hep D if you haven't had Hep B. It's transmitted by parenteral route. The incubation period is anywhere from 1 to 6 months, and mortality is about 3%. Hep E is similar to Hep A, but not as easily transmitted, and it's transmitted through the fecal-oral route. Incubation is anywhere from 2 weeks to 2 months. There's no carrier state, and the mortality rate in pregnant women is anywhere from 10 to 20%. Hep G is transmitted percutaneously. It's a co-infection often with Hep C, and in patients with HIV infections, co-infection with Hep G improves overall survival. Chronic hepatitis is seen with elevated ALT and AST levels for more than 6 months, and hepatitis B and C viruses produce chronic hepatitis. So those patients that have chronic Hep B, 40% of them will develop a cirrhosis, and then 20% of these patients with Hep C may develop a hepatocellular cancer. So now that we know about all the specific types of hepatitis, let's talk a little bit about patho of them. We know that it's an inflammation of the liver that's caused by a variety of factors. Viral hepatitis usually presents in one of 3 clinical ways, whether it be anictoric, icteric, or cholestatic, and despite however it might present, the disease is going to progress in the same pattern, differing only in the severity and the possible outcomes. And regardless of the type of hepatitis causing the infection, the liver acini cells are affected by a patchy cell dropout. You will also see acidophilic hepatocellular necrosis. There will be scarring of these cells. We can have hyperplasia of the Kupffer cells, and then there's inflammation of the mononuclear cells, and they'll have an infiltrate. The degree of cell damage is proportionate to the severity of the infection, and the hepatocellular injury is mediated by cell-mediated immune responses. Also of note, though, is from histological exam of tissue from the liver that has been infected with hepatitis shows that early on in the disease process, the liver is regenerating itself. Okay, let's talk a little bit about clinical presentation. And hepatitis can present from being asymptomatic to death. There can be a prodromal phase where you will see anorexia, nausea, vomiting, malaise. The patient may be tired, they may have abdominal pain, there may be fever, there may be a respiratory infection. The enteric phase is when you may see jaundice, dark urine, and light-colored stool, and then convalescent phase is an increased sense of well-being. Their appetite begins to return. You might notice jaundice, that the jaundice, abdominal pain, and being so tired are improving. So we're going to talk a little bit more in detail of the different hepatitises. On the hepatitis A, the diagnostic test that you would run, or what you would see, you would notice that an IgM anti-HAV appears 4 weeks after exposure. An IgG anti-HAV appears 2 weeks after the IgM anti-HAV begins to increase. The IgG persists for about 10 years and provides immunity, and if the IgM is elevated in the absence of IgG, then acute hepatitis is suspected. IgG is elevated in the absence of the IgM, and past exposure or non-infectiveness and immunity to hepatitis A is noted. These are all things that you're going to You may make initial diagnosis, but you're also going to be caring for this patient with the help of a gastroenterologist. So it's important to be familiar with this, but these are not things, unless you're in some type of hepatitis clinic, that you'll be using on a daily basis. So be familiar, but it's not something to be overly worried about that you have to commit to memory, other than know where to go to learn more about it and to see what is happening with each hepatitis and what's going on with them diagnostically. The tests for Hep B include a Hep B due to its inner core that contains the Hep B antigen, and it's surrounded by an outer capsule that contains the Hep B surface antigen. So detection of the Hep B antigen is diagnostic for Hep B, and it appears in the first 1 to 10 weeks after exposure and remains positive during the acute phase. If it persists longer, you might suspect a chronic disease. The IgM anti-Hep B appears shortly after the Hep B antigen and persists for anywhere from 3 to 6 months. The IgM anti-Hep B is diagnostic for acute hepatitis, and it's present in recovery and for life. Hep B diagnostic tests include an anti-Hep C by an enzyme immunoassays, and then the hepatitis C RNA detects the actual virus. Hep D is detected with an anti-Hep D virus, and then the hepatitis D RNA test, and both must be seen in the presence of Hep B markers. With hepatitis, you'll also see elevated AST and ALT. Bilirubin may be elevated, and albumin and prothrombin can be indicators of how well the liver is functioning through all of this. Other differential diagnoses that you need to include are other viral diseases that can impact the liver, such as mono, cytomegalovirus, and herpes, or drug or toxin-induced liver damage. The goal of management for all hepatitis cases is preventing transmission and symptomatic relief. So we know that vaccinations are available for both Hep A and B, and it's important to have good nutrition, avoid alcohol, and to have activity restrictions during the acute phase due to the fatigability that is associated with it. Treatment for Hep B includes a pegylated interferon alpha 2A. There are antiviral agents. You can perform or have a liver biopsy performed to determine response, and the response rate, though, is only about 40%. For Hep C treatment, there's a pegylated interferon and ribavirin in the acute phase that is known to decrease the risk of chronic Hep C. This treatment best responds to genotype 2 and 3. Treatment is given once a week for 48 weeks, and a liver transplant is indicated for those with advanced liver disease. Follow-up and referral for hepatitis is anyone diagnosed with Hep C should be referred to an hepatologist. Patients with Hep A usually do not require follow-up, and patients with Hep B should be seen in 1 month and should have blood drawn for antigens after 6 months. And if there's a persistent elevation in the Hep B antigen, it indicates a chronic state, and so these patients should be referred to the hepatologist. Our last slide of this section is patient education, and instructions about the cause of hepatitis need to be passed along to the patient, the mode of transmission, and measures to prevent transmission. It's important that they know about household contacts and sexual contacts, should be given passive immunity for Hep A and B, as well as active immunization. Good hand washing is necessary, and personal hygiene can prevent the spread. There needs to be no sharing of personal items such as toothbrushes, razors, or eating utensils during the period of being infected. And patients with acute or chronic hepatitis, or those that are being in a carrier state, should be instructed to practice safe sex. So that's going to be the end of hepatitis, and we will start again with cirrhosis and liver failure. Thank you.